Hello and good evening, friends. Today is the last talk in the resident series of the ACNS webinars for the month of October. Today, we are going to hear about a specific approach to petroclival region. One of the most earlier and comprehensive approach to this region was described by Professor Takeshi Kawase in 1985. Initially, he described this for low-lying aneurysms, and thereafter this technique was later expanded for accessing various pathological tumors in this region. As you all know that recently there has been a different approach that is through the retrosigmoid, also known as the RISA or the retrosigmoid intradural suprameatal approach. And this is popularized by Professor Tatagiba, who named this as a reverse Kawase approach. So we have Professor Tatagiba with us to teach us more about this approach. Professor Tatagiba is the director and head of the Department of Neurosurgery, University of Tübingen, Germany. He was also the past president of the German Academy of Neurosurgery and German Skull-Base Societies. He was also the head of International Affairs, German Society of Neurosurgery. Professor Tatagiba has been decorated by many awards internationally for his outstanding contributions to neurosurgery. He is a prolific researcher who has more than 360 manuscripts and several books and chapters to his credit. We are so thankful to Professor Tatagiba to have accepted our invitation to speak at our webinars. To chair this session of Professor Tatagiba, we are honored to have with us Professor Eckhard Casper from Ontario, Canada. Professor Casper is the professor of McMaster University and Hamilton General Hospital, Ontario, Canada. He has a vast experience in neurosurgery, having affiliated with world-renowned institutions like Harvard Medical School, Beth Israel Deaconess Medical Center, and Massachusetts General Hospital. He is an integral member of all major neurosurgical societies, namely the CNS, AANS, ACNS, and WFNS. He is also an acclaimed researcher with more than 200 publications to his credit. He is on the editorial board of most of the major neurosurgical journals. Today, we are so glad to have him with us to chair this session of ACNS webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I hereby welcome today's speaker, Professor Marcos Tatagiba and Professor Eckhard Casper to this online platform of ACNS webinars. Dr. Liu Bunseng from Malaysia is my co-host for today. And with that introduction, may I please hand over this podium to Professor Casper.
Thank you very much for your kind introduction. A brief presentation which allows me to introduce you all to the topic. So I thought as a brief general introduction, only taking about 5-6 minutes, I want to give you a brief overview to the problem at large. So I have nothing to disclose, but I'm very happy that Yoko and Raja invited me to this seminar. And I want to briefly go through a general introduction, talk about surgery versus radiosurgery for this particular problem, strategies that have changed over the last few decades, and then lead over to Dr. Tatagiba's talk to give us an outlook on how to approach this best. The basic problem is, how do we get from a defined problem that we see from the CP angle on the left side to having this lesion removed? So for this purpose, definition of petroclival meningiomas should be that we probably deal with lesions of the upper 2/3 of the clivus. They are originating either on the clivus or at the petroclival junction. They're usually medial to the fifth nerve, and most of them are considered benign on histopathological criteria if you have a tissue available. Clinical relevance is that the natural history of these is known. They are usually slowly progressing clinically, rather mildly, but 50 to 75% will show radiographic progression over a course of 2 to 5 years when followed sequentially with MRI imaging. We all think the goal of surgery in most meningiomas is to achieve a gross total resection, which means really removing the Dura, the tumor, the bone, and we all aim for a Simpson grade 1, but this concept comes from convexity meningiomas. And the problem is gross total resection in skull-based meningioma cases is often not feasible. So early on in the 90s, Bob Ogeman already said it's not wise to have a great scan with a gross total resection, but very poor clinical outcome. And that has been reiterated over the last 25 years by Basan Misra, who I think gave a good quote: the best treatment is not the best for the tumor, it's the one that is best for the patient. So what are factors that make resection difficult in this location? Well, petroclival meningiomas often have supra and infratentorial components. There often is a wide-based attachment. There are adhesions to neurovascular structures that may be encountered, cranial nerves as well as brainstem and vessels. There may be infiltration of the cavernous sinus and the foramina of the exiting nerve roots, and bone infiltration. And then in addition comes a layer of surgical experience with rare lesions, not always available in each center. And it depends very much on your chosen access and the viewing angles provided. So when you block this out over the last few decades, there's really a change in petroclival meningioma management. Prior to the 70s, this lesion was largely considered unresectable because intra-hospital mortality was 50% or higher. Morbidity was atrocious, and only in the 80s, with progressive introduction of microscopes and intraoperative monitoring, complete resection was really attempted. Whereas then in the 90s, the trend is more towards maximum safe resection followed by some form of radiation. So the shift has happened to limit morbidity and preserve neurological function and quality of life. So why is that so? If you look at the literature, you can really sort of divide it into maybe two phases. The one prior to 1995, where gross total resection rates were roughly reported around 80%, but at pretty bad morbidity. And after 1995, this gross total resection rate in most series dropped to about 40% because people started employing adjuvant therapy. This is very well summarized in Basan Bisra's chapter that he contributed to Al-Mefti's Controversies in Neurosurgery book from 2014, which I recommend everyone to read. You can see that even in Basan's own hand, and he's a very gifted surgeon, he had about 70% gross total resection rate prior to 1997. And as he was trying to be more gentle with limited morbidity, which initially was 18%, his gross total resection rate dropped to below 40%, but his morbidity was cut down to a quarter. And the reason for that shift really was both the invention of radiosurgery or radiation means, but also the observation that subtotally resected tumors had a rather slow regrowth rate of about 5% at 5 years. So this change really came through the advent of initially gamma knife radiosurgery as primary or adjuvant therapy. And when you know from other meningiomas that your local control rate with radiosurgery is about 90% in benign disease, then you need to know that progression-free survival in cases like this for skull-based meningiomas are in the range of 90 to 95% at 5 years, maybe 85 to 90% at 10 years, with neurological improvement in about 40% of patients and stability in about 54% of patients. So you need to have a really good argument to say you go for a surgical procedure that carries significant morbidity. The risk of radiosurgery, just to summarize, is roughly 5% for radiation necrosis, but it's largely dose dependent. And there's a small risk associated with neurological worsening, largely cranial nerve deficits. So since the advent of gamma knife radiosurgery or other forms of Lennart-based radiosurgery, it has really changed that now I think most of us skull-based surgeons think about who is the right patient for what type of intervention. Gross total resection goals remain valid and should be attempted. If you see a good cleavage plane on pre-surgical imaging, and my favorite sequences, MRI T2 sequences or CIS sequences, where you can actually see preserved arachnoid and CSF, then you probably have a good separation plane from neurovascular structures. And if the tumor is not too broad-based, I think that will also lend itself to a better resection. Subtotal resections are perfectly acceptable if there are excessive adhesions, if there's a peel breach visible on pre-surgical scans, often reflected by brainstem edema, or if there's white skull base attachment. So what is the best approach to take these out? I want to hand this over now to Dr. Tatagiba and tell us his approach to tackle these formidable regions. Thank you very much for inviting me to you.
Thank you very much, Dr. Kasper, for this excellent introduction to prepare the audience for this lecture. I agree 100% with your statements. This is exactly the point. And my intention here is try to stress the use of the posterior approach, that means the retrosigmoid approach, to attack these lesions. Although you will see sometimes I'm talking about true petroclival meningiomas. Sometimes I'm talking about meningiomas of the petroclival region, and not under the strict sense of petroclival meningioma itself. But it's to share the idea to remove this tumor from the other way instead of coming from above. I have no disclosures related to this lecture. I would like to start with such a picture. Petroclival meningiomas, they may be actually impossible to treat completely, like this case here. This is a sphenopetroclival meningioma extending into the extracranial spaces, cavernous sinus, engulfing and invading the carotid artery, the nerves, posterior fossa. Sometimes in cases like that, the best thing to do is just to wait, or send the patient to radiation. The maximum you can do surgically for these cases to decompress the brainstem if the patient is suffering from brainstem compression, and to allow for a better radiation to this tumor without involving the brainstem. We know from our series that these tumors may remain quiet for many years. Like this case here, for 11 years, the patient remained radiologically and neurologically stable. At that time, we suggested surgery to her, but she refused, and we must say the patient was right. So she remained stable for 11 years. On the other side, we have done some studies on natural history, like other people have done as well. And we have seen that at long term, the majority of petroclival meningiomas will present some growth. And those who present growth will have deterioration, neurological deterioration, in 63% of the cases. That means in a number of patients, there will be a need of treatment, any kind of treatment. So all these cases are petroclival meningiomas or meningiomas of the petroclival region. We treated in our institution, it's about 106 cases. When we are talking about surgical treatment, we must describe three major approaches. The first one is the anterior petrosectomy. Actually, the middle fossa approach itself was described very early in the last century, for instance, by Dr. Theodor Krause. And other people have done similar approach like these described by Professor Kawase, but he was the person who really popularized this approach and made this approach really available to everybody. And the second one is the posterior Petrosal approach, very much popularized by Dr. Mefti and Dr. Sami in the 80s and 90s. When I started my residency program with Professor Sami, end of the 80s, I remember that all petroclival meningiomas have been operated on via this approach. It was a combined presigmoid subtemporal approach. And what we have seen is that in many cases, it was really not necessary to do such a large exposure to remove the tumor, or at least to remove the major part of the tumor. And we got some complications related to sinus thrombosis or compression of temporal lobe or vein of Labbé and so on. And more, the Retrosigmoid approach was chosen for these cases, but one variation, and this variation was actually first described by Professor Sami, which was drilling the bone above the interauditory canal, that means the suprameatal bone, and removal of the tentorial. So these are the three basic approaches. So this is the posterior transpetrosal approach. Again, thus just the a graphic drawing of the craniotomy and the craniectomy or mastoidectomy, we do in these cases. But this approach became, as I said, less common in the last years or decades. I'm not going to show this approach because this is not our point. And the second one with the anterior petrosectomy, as I said, very much popularized by Professor Kawase. And what he did was he did an extradural exposure of the structures of the middle fossa, and he drilled away the bone located anterior to the interauditory canal. And this way he could achieve a good access to the posterior fossa. This approach is an excellent one for those lesions which are mostly located at the middle fossa, but also entering the posterior fossa. This approach is not ideal for those lesions which are located below the interauditory canal, because visualization is reduced in these cases. So in these cases, we recommend posterior approaches. I'm going to show you in this lecture. These are typical cases that are usually removed by Kawase approach. What I'm going to show is that these lesions can also be removed by posterior, or what I say Kawase reverse approach. My problem with this approach is, for instance, this one. I have seen cases in our series and on the series of others in which the temporal lobe is looking like that after surgery. And if this is done on the left side, the patients can develop aphasia, seizures, or at least cognitive disturbances, mood changes, and so on. And this has been reported by others. And in this case, for middle fossa approach to vestibular schwannomas, and also these cognitive disturbances have been reported in comparative studies in which the middle fossa approach was compared to a translab approach in vestibular schwannomas. The question is, or the question was, how can we avoid the temporal lobe retraction and do a resection of this lesion? So this was the primary idea. It was published first time clinical. This is the first clinical paper on this issue. On the same year, there was an anatomical paper published by Professor Roton's group, but this is the first clinical one, and in which these approaches described. And recently, we made a comparative study, anatomical study, comparing the reverse Kawase approach with the true Kawase. And the name Kawase reverse approach was approved by Professor Kawase, who very gently allowed me to give this name to this approach. So when I say we enter the posterior fossa and so on, I would like to pay attention to one point. Of course, we accumulated a large experience treating posterior fossa lesions. This is not the case that we just changed the approach and started doing for the first time these lesions. So one very important aspect is to get experience with the CP angle, with less difficult lesions. In these cases here, our series of vestibular schwannomas in this institution. But before I have done it in Tübingen, I accumulated experience also in Hanover and in Freiburg, where I have been working as well. For these lesions, if the tumor is large, we put the patient in semi-sitting position. Semi-sitting position will facilitate a lot tumor removal. There is less bleeding. There is a better view of the field. And very important point, our angle of attack is from below to above. So these will make surgical removal, including transection of the tentorium and removal of this bony part, much easier than if we use a supine approach, a spark benches approach, or something similar. So semi-sitting position is part of the approach, is part of the surgery itself. It should not be underestimated. So we do a usual craniotomy as we do for vestibular schwannomas with one straight skin incision. And the Dura incision is just a simple one. We don't do additional incisions because these will facilitate a lot Dura closure later on. And when we enter the CP angle, this is a very important point. We are watching from below to above. We can visualize the superior parts of this compartment very well. So spatula is not inserted like this. A spatula is inserted from below to above, and we must pay attention to open the inferior part more than the superior one. Why? Because here is located the petrosal vein. If we insert our spatula at this point, there is a high risk of rupture of the petrosal vein. What petrosal vein may mean for these cases, I will show you at the end of my lecture. But pay attention to open the cisterns as first step and to do the retraction at the inferior part more than at the superior part. The angle of attack is from below to above. And these are the anatomical landmarks for this approach. You see here, this is the CP angle, lower cranial nerves, 7 and 8 nerve. This is trigeminal, petrosal vein. So in vestibular schwannomas, we are used to open this part of the bone, to open the internal auditory canal. At this Kawase reverse approach, we open the bone above the internal auditory canal. This way, we get access to the posterior part of the Meckel's cave, and we can add to this bony removal resection of the tentorium. So we can come laterally. You see here, this is the middle fossa. And you can also come supracerebrally, so that if you are coming from more medial, you have a better view to the lateral aspect of the middle fossa. So this is the internal carotid artery. And you can see at the end of the resection, you can see oculomotor nerves. Depending on the case, you can see up to the optic nerve with this approach. So this is one example, a clinical case. You see here, the trigeminal nerve is bulging to the posterior part. The tumor is coming from anterior. You might think that it's not possible to do. You see, you have the trigeminal nerve in front of you, and it's much better to come from above. But this is the point. First, I want to avoid temporal lobe retraction. And on the other side, I want to have a better control of the part of the tumor, which is for me the most important one. That is the posterior fossa portion of the tumor. This is for me the most important one. So what we do is we dissect the arachnoid, and we can gently mobilize the tumor, perform resections, and then at the end we achieve this point. You see, tentorial is removed, the bone is partially removed. We can see here, this is the oculomotor nerve in front, and this is after removal. So now some clinical examples. Not all of these cases are true petroclival meningiomas. I'm gonna show also some other examples like Petrous apex, some large CPA meningiomas which are extending into the petroclival area, and so on. So first one is a small tumor, but sometimes these small tumors are even more difficult because they have not created the space you need to remove them. So this is a Petrous apex. Usually you can do this surgery via more anterior approaches, but remember, this is the left side. You have to retract the temporal lobe over a long period. So, and what we do is this one. Retrosigmoid approach under electrophysiological control. So this is the suprameatal bone. This is petrosal vein, trigeminal nerve. So because tumor is located in front of these structures, So we start drilling the suprameatal bone. Then we have a better access to the posterior part of the trigeminal nerve. We dissect and do everything to preserve the petrosal vein. Sometimes not possible to preserve it, but we try at least. And you see, then we start tumor removal, piecemeal removal of this tumor. We can use cavitron as well. If we are working very close to nerves, we can use, so I like to use a piece of gloves in order to protect the nerves. Then we open the tentorium, paying attention to save the trochlear nerve. And the trochlear nerve is actually the most endangered nerve in these approaches. If you lose the trochlear nerve, this is not a major issue for the patient. The patient will compensate well, or the ophthalmologist can compensate. Of course, we try to preserve it, but it's sometimes not really possible because it's too long, too thin, too much attached. So this is at the end, you see the patient will tolerate well the surgery. These hematomas are caused by the needle to control the sixth nerve on both sides, you see, and this is 2 years after surgery. What you see is that tumor is very well removed at the posterior fossa. This part of the tumor attached to the lateral wall of the cavernous sinus and Meckel's cave, if it's too hard to remove, we don't try to remove it. We can, our experience is that we can follow this lesion over a long period, and this is a part of the lesion that can be irradiated. So this is a multimodal treatment of those tumors. At least the patients are in good shape and stay stable for a long time. This is another case. We did this case in supine position just to show the use of endoscope in these cases. After you have drilled this bone, you can use the endoscope to enter this cavity as well. So this is temporal lobe after removal of the tentorium, and then we can do the removal of the meningioma as well. So sometimes we have to drill more. If the petrosal vein is a big one and it's disturbing, then we have to be more careful with these removals. So this is the removal of the lesion. This is the bony resection. This is following removal of this lesion from below. And as I said, an advantage is that temporal lobe is completely intact. And if this is on the left side, I'm very relaxed that this patient will not develop any cognitive disturbances. And as I said, it's well tolerated, and it's not true as sometimes it's said that this approach will endanger the facial nerve in many cases. So this is not our reality. Our reality is that facial nerve can be preserved in the majority of the cases. And so this is meningioma located at the CP angle extending into the petroclival area. So as I told you, we retracted the inferior part more than the superior. Pay attention that please do not use cavitron at the beginning. You must first of all check where the nerves are running. Otherwise, there is a risk to catch these nerves with a cavitron. So we must do dissections and careful removals. Sometimes vessels are very adherent and we have to leave some pieces behind, but with patients we insist, and you can see here that sitting position helps keeping this area clean, and under irrigation we can achieve a good resection of this lesion with preservation of the structures. And the patients will tolerate well this resection. You see here the patient at the intensive care unit immediately after surgery with a good facial nerve. Sometimes the tumor is located at the posterior fossa and entering solely the Meckel's cave. This is not a real petroclival meningioma, although it's located at the petroclival area. But you can say that this is a meningioma of the petroclival area and the macroscope. So what we do in these cases is very similar to a vestibular schwannomas. What we do is we enter the posterior fossa to remove this tumor. So the tumor is displacing the trigeminal nerve below and posterior. That means the tumor is located primarily anterior and medial to the trigeminal nerve. And then when we have removed it, we enter with the endoscope and perform the suprameatal bony resection to open the macroscope. These will allow to expose the part of the tumor which is in the macroscope. And then we enter again with endoscope to double check. And this is the final view. You see here, this is the macroscope seen from posterior. And this is the 7 and 8 nerves. We drilled away this part of the bone. This is the trigeminal nerve bulging upwards and the Petrosal vein. So this is the final view, and you see the resection and the patient. He had a Haus-Brackmann 2 after surgery. Later on, he improved to Haus-Brackmann 1. And so the same strategy like in trigeminal schwannomas. In these cases of trigeminal schwannomas where the tumor is dumbbell shaped and the posterior part is large, if the anterior part is larger, then we enter through the middle fossa. But if the posterior part is much larger, then we enter through the posterior fossa, and through this enlarged opening of the trigeminal cavity, we remove the tumor. So this is after removal using just the posterior approach. So such meningiomas we like to do in sitting position. As I told you, you can see here the Petrosal vein, the meningioma, 7 and 8 nerves. You can't see in this case immediately the trigeminal nerve, and later on this tumor will be exposed. You see here the 4th nerve, and more anteriorly you can see the oculomotor nerve, the carotid artery and posterior communicating. You can see the more anterior structures. So this is the patient afterwards with oculomotor function. And as I told you, sometimes we leave parts of the tumor connected to the lateral wall of the cavernous sinus, and we just follow up these cases. You see here this older patient, small tumor on this part, larger tumor posterior, and this approach is excellent for these lesions like this. We can remove the tentorium, and we can remove part of this tumor. So again, we open the cistern, we expose this lesion, and then important is to do careful dissection of the arachnoid. And I don't start immediately with cavitron. I open first with the tumor forceps to localize the nerves, and then I use the cavitron. And so the tumor is diminished in size, and then I try to detach the lesion from the surrounding nerves. Still bloody tumor, but under the sitting position, you see better under irrigation, and we use, this is the 5th nerve. You see here the 5th nerve dislocated downwards and posteriorly, lower than the 7 and 8 nerves. So the trigeminal nerve was lower than 7 and 8. And then you will see the trochlear nerve. Trochlear nerve is very thin, and during these dissections, sometimes it ruptures. If it happens, it's a pity, but the patient doesn't have a major deficit for this. The patient will compensate later on, tilting the head to the side. So some patients, they come with trochlear palsy and they don't realize that because they become used with this position. So then we continue and detaching the tumor and removing the structures. Because the patient is older, the major point was here to remove the tumor at the posterior fossa and not too much at the area of Meckel's cave and close to cavernous sinus. So here we are now opening the Trantentorial. The Trantentorial is being transected to allow better visualization to the supratentorial areas. Still, we are fighting with the trochlear nerve. Very thin, you see, it ruptures easily. We must be very, very delicate with these removals. But the angle of view, you can realize the angle of view is from below to above. Now we see here, this is the clivus area, and we can see the pituitary stalk. This is the third nerve. And this is at the end what we could achieve in this case. So now we can clean a little bit more. And this is what we could achieve in this case. And look what happens with the patient. So we worked a lot on these nerves. We worked a lot on these nerves. This is the CT scan showing the removal immediately after surgery. And now we can see the, just a moment. Just have to push my slide anterior. So, yeah, this is the patient 3 days after surgery. You see a good facial function. It was not disturbing for her, all these dissections close to the facial nerve. So this is the removal of the tumor, and we left this part here. Because of the age, we didn't force too much. But you see the supratentorial part was otherwise removed. This is 5 years after surgery. This area is still quiet. So we don't go for immediate radiation. We wait what happens with this area later on. This is younger patient. In this case, we did, let's continue here so that we don't lose too much time. So in this case, the tumor was soft, but you see, we don't retract too much the posterior fossa to avoid rupture of the petrosal vein. So we start with tumor dissection, diminishing the tumor size. Let's come more forward. And so tumor was removed with diminishing size, and then we detached the tumor from the surrounding structures. And at my surprise, the tumor was really could be detached from this area. And now we can see all structures here, fourth nerve, brainstem, and others. And in this case, we didn't need to remove tentorium. And at the end of the resection, I entered with the endoscope just to make sure, because whether we had really removed everything, because it was not necessary to open the tentorium in this case, but indeed the tumor was removed. You can see here the prepontine area, and there is no significant tumor, just some small pieces that we could remove later on. So this is the postoperative result. You can see here we could remove this part. This is a true Petroclival meningiomas, young male patient with some edema of brainstem. Every time we found this situation, we found also infiltration of the veins. So this was very important. The patient did well, but 3 years later he developed recurrence. We removed again the tumor, and this tumor became malignant. So after radiation, another recurrence, and it was first atypical and then anaplastic meningioma. At the end, this patient died from this malignant disease. Very interesting, because the first tumor was WHO a normal meningioma. Now this patient here with CPA meningioma growing up to the clivus, and so this case, I think I have showed this case before. Let's come to this here. So this is a very large Petroclival meningioma with engulfing the basilar artery. And also in this case, we did just a retrosigmoid approach. You see here opening of the cisterns, opening the inferior part more than the superior part. The petrosal vein is preserved on this area. And then, of course, you can imagine this is a surgery, it takes several hours. We have to work between the nerves. This is a disadvantage, but this disadvantage is not a problem. So you can diminish the size of the tumor, performing enucleations, working in between, but with gentle measurements, the nerves will not suffer. We do see temporary palsy of the facial nerve. We do see hearing loss, but we have several cases the patients will improve hearing after surgery and after the meningioma has been removed. Different than vestibular schwannomas, in cases of meningiomas, you may have even improvement of hearing in some cases. So now the more superior part of the tumor, as I demonstrated in the other cases, and continue now these removals. And so let's come to the result. You see here the removal of this lesion. We had in this patient, the brainstem was very much displaced. Patient developed the Haus-Bregmann 4 facial nerve. Later on, this facial function came to Haus-Bregmann 3. So this is another case of Petroclival meningiomas growing up to the supratentorial space. This is ideal case for the Kawase reverse approach. And so this is not a case I would really recommend to go from above. And this is the patient later on, good condition, good facial nerve. Initially, he had a facial palsy, but he covered very well, you see, and tumor is good under control. But when we are faced with this kind of lesion, for us, it's clear we cannot remove this tumor with one surgery. And I would not recommend to try to remove this posterior part from anterior, because it means for this patient too long surgical time retracting the temporal lobe. In this case, young patient, she was pregnant when she came to us. We waited until she delivered the child until everything was fine. And then we did this surgery in 2 steps. We removed the posterior part first, and then later on, we removed via a pteryginal transsylvian approach, we removed the second part. So this is after the first removal and after the second removal. You see here, still there is tumor within the bone, surrounding the carotid. This is something we didn't attack with surgery, and the patient did very well without neurological deficits. And we are following up this tumor. Of course, she's very young. She's very much likely to develop recurrence, and we are gonna do radiation. Our policy in these cases is to do first a PET MRI with a somatostatin receptor tracer like dotatate or domitate tracer. So to localize exactly the area of the meningioma, and then we go for fractionated stereotactic radiotherapy. And this is another case. The patient had visual dysfunction, so we did the surgery in two steps, followed by radiation in this case. So this is the first, the second, and the patient afterwards. And she did well with this more conservative approach. We didn't attack these parts of the lesions. So in summary, we can say this approach is a very straightforward because retrosigmoid approaches, they are as common in neurosurgery as pteronal approaches. In our experience, this is an approach with very low morbidity related to the approach itself. You can have an excellent visualization of the posterior part of the tumor, a good visualization of the middle fossa, but not if the tumor is very large at the middle fossa. In this case, we prefer to do in 2 steps. The great advantage is no temporal lobe retraction and as I said, good control of the posterior fossa parts of the tumor. Be careful with the manipulation before you start doing these surgeries. You must be familiarized with posterior fossa, with CP angle lesions like vestibular schwannomas and others. And the first part of my talk, just a couple of minutes, I would like to show to you in our experience the significance of petrosal vein for outcome in these cases. So we have had some complications in case that petrosal vein was sacrificed. So we started to do a careful study on that. So we took 59 cases of Petrous apex meningiomas, that means very homogeneous group of lesions. We did a retrospective study, checking video recordings, outcome reports, and so on. In 27 patients, the vein was preserved. In 30 patients, the vein was sacrificed. In terms of lesions, they matched because they were very similar lesions. In 2 cases, we couldn't identify the petrosal vein at the video recording, so we excluded these cases. We found 1 single petrosal vein in 70% of the cases. In 22%, there were 2 veins. More than 2 veins was less common. And what happens was that in the cases where the vein was preserved, we didn't find any complication related to cerebellar edema, bleedings, hydrocephalus, something like that. In the vein sacrificed group, we found among 30 patients 9 cases of complications. Fortunately, most of these complications were minor complications like edema of cerebellum, but transitory one, hydrocephalus that could be treated with external ventricular drain for some days, not long. In 1 case, we needed VP shunt, but we had 1 case of venous infarction. I would like to show to you these examples. So again, most of cases, you can sacrifice the petrosal vein. That's true. The problem is that we don't know which case will cause trouble, and this trouble may be very significant for the patient. Like here in this lady with infiltrative sphenopetroclival meningiomas, our goal was to remove this posterior part and send the remnant for radiation. So I removed this part. Petrosal vein could not be preserved. The patient awaked from the surgery well, but at the same night, she deteriorated, became comatose, had to be intubated again. And you see this very typical bleeding caused by venous congestion at the posterior fossa, these strias of bleedings, and the patient has, in this case, has to be decompressed immediately. So we opened the posterior fossa, we removed part of the cerebellum. It took several weeks until she recovered. She recovered well, but she remained with some ataxia. And so this was a significant complication for this patient. Fortunately, the lower cranial nerves were intact and she can walk, but still with some difficulties. So this is our message regarding petrosal vein. It may produce minor complications in 30% of the cases. In 5% in our hands, we saw serious complications. That means whenever possible, try to preserve the petrosal vein in these cases. So this is a summary of this lecture. I would be very glad to discuss with you several aspects we could not address to. It was a pleasure to be with you these minutes. Thank you very much.
Yes, thank you very much, Dr. Tatagiba, for a fantastic talk and beautiful material to address a number of questions in this arena. I think I have a couple of practical questions that you can help maybe the less familiar newer generation of skull-base surgeons how to tackle these cases. So I think your most relevant advice, because I came through the same learning experiences, be familiar with the approach. You know, I trained with Pope Ogeman. The Intratentorial retrosig approach was clearly the way to learn the anatomy in this area from a beautiful viewing angle. And I think if you have good experience with acoustic surgery, you are more prepared to do Petrous apex surgery. I think that was fantastic advice. Now, when you set up your case, maybe you can briefly tell the audience, what do you monitor? I monitor sensory evokes, motor evokes, and then 5, 6, 7, 8, 10. Is there anything else besides direct nerve stimulation you would recommend?
Yes, I use for facial nerve, I use MEP, not just a direct stimulation, because in these large lesions, sometimes we don't see immediately the facial nerve. And it's quite comfortable to know that the facial nerve is in good condition, even we have not seen it. I use the MEP of the facial nerve for large acoustics as well, and for these meningiomas. And yeah, I use monitoring of lower cranial nerves,
right.
Mostly for 9th and 10th. 12 is not necessary. 11th is also not necessary.
Yeah, same in my experience.
The only disadvantage of sitting position in these cases is that sometimes you have subdural air. In 3% of our series, we have now about 900 semi-sitting positions done for different pathologies. And in 3% of the cases, we had significant air subdural, and these can change your MEP monitoring. So in these cases, we must rely more on direct stimulation of facial nerve.
That's an excellent aspect. I still do most of mine in 3/4 prone, or like Ogeman supine with the head to the side, but it's because the institution is more familiar with that approach. I was interested in when you showed the case of trigeminal schwannoma reaching fairly laterally. So coming in from suboccipital, your viewing angle is somewhat limited by the petrous portion of the bone. Have you ever had to take out a portion of the cerebellum to change your viewing angle? Or how do you scale the size of your bony suprameatal resection?
Yeah, no, for these cases, it's interesting to go supracerebellar. Then you have a view from medial to lateral. So I use then an angulated endoscope, 45. And I like to use, this is not propaganda, this is just I want to mention, I like to use the Capabianca instruments, angulated curette to remove this. We achieve a very good resection but I have seen recurrence of trigeminal schwannomas. But I believe we are not the only group that observed recurrence of the trigeminal schwannomas. This is not very uncommon to have it.
Yeah.
But it's a good, you know, if the anterior part of the trigeminal schwannomas is larger than the posterior, then I use the middle fossa approach, peeling the dura and so on, the very common described procedure. But if the posterior part is the largest one, then I have seen that coming from posterior was easier to achieve the goal.
Yeah, it slowly widens your Meckel's cave axis so you can peel it out with angled instruments. Do you have any hints for newcomers in the field how you open your tentorium from below? Because when you have that viewing angle, there are different strategies. Some people make a very superficial incision, put a paddy above, so in the supratentorial component, and then use an angled knife, a scimitar blade, or do you put a stitch in and pull the tentorium down? Just give a practical advice how you would do that.
What I do is I go along the border of the Petrous bone for the first incision of tentorium. Okay, so I just go some millimeters medial to the tentorial to the bone, okay,
yeah.
and then just open the tentorium, watching the fourth nerve. When I have opened this, I mobilize the tentorium to see whether there is a very much tumor medially, laterally, and then I do the resection of the tentorium. So I don't start resecting the tentorium in one piece. What I do is, maybe there is a better solution for that, but what I do is I open the tentorium first, then I check what I need to increase the removal in order to see better the tumor. So, okay. Did you get the point? I don't know if I could.
No, I know where you're coming from. I just thought there's sometimes like a trick of the trade you want to pass on. Then, with respect to post-surgical follow-up, not every institution does volumetric MRI scanning and measuring the size of your residual. Would you recommend this? One of the big problems in comparing series and, you know, who has what type of resection is the use of the words near total, subtotal, you know, almost total excision is not really quantifiable. So recently people have advocated for volumetric MRI scan to say the contrast enhancing portion of the residual disease was about size X. And then how often would you scan to see when recurrence occurs?
The point is, we used to do the first MRI 3 months after surgery. At that point, we see a lot of contrast enhancement, also in vestibular schwannomas. And you know, probably you have the same experience. The patients come sometimes upset, saying, my radiologist said you left tumor behind. And you see some contrast enhancement. This is not tumor, this is just vascularization. And in meningiomas, this is even more evident. Okay, so important for me is not that you see that, but what happens with the next years. So the first picture is 3 months after surgery, and then 1 year later, and then again 1 year later.
Yeah, I do the same.
Very quiet, we can double the time. And in case that we decide, I don't know if I could mention this with evidence, in case that we see some remnant, what we do is we can do this in our institution. Many institutions can do that. We do PET MRI and with somatostatin receptor tracer. And then you can quantify exactly the area of the meningioma remnant, because contrast is not enough. And regarding tumor resection, I prefer to divide which compartment I'm talking about. So if my intention is primarily to remove the tumor of the posterior fossa and supratentorial as well, but I'm not intending to enter the cavernous sinus, then I quantify my tumor resection on these areas, okay, then I can say, okay, in 70% of the cases, these approximately our numbers, in 70% of the cases, I could do Simpson 2 removal of the posterior fossa. But if I include every time again the lateral wall of the posterior, the scavenous then this total removal will drop to 30 to 20%.
Yeah, I think that's a very smart advice. Yeah, and I actually recommend also for listeners to initially not try to attempt to go into the cavernous sinus. That's the portion of the tumor, I'd say, that can safely be left behind. That compartment usually tolerates changes over a longer period of time. There's a slow growth pattern to it, can be well radiated, and less morbidity in removing that last bit of the tumor that has the highest risk of causing trouble. I wanted to invite the audience to ask a few questions. I didn't see anything in the chat box, but is there anyone in the webinar who would like to express a question?
Yes, Professor Hideyuta Kumura, would you like to ask something?
Okay.
Hi, Professor Tatagiba. Nice to see you again here. I met you several years ago at Kobe City. Do you remember me? Yeah, thank you. So an excellent presentation today also. So, and I totally agree with your comment, opinion. And we should preserve all Petrous. We should preserve Petrosal vein also in treating the posterior fossa meningioma. I understood from your presentation. So today I learned a lot. So actually, almost all Petroclival meningioma can be removed your reverse Kawase approach. So what is the technical limitation of your approach to remove the posterior fossa meningioma? So because you approach almost all posterior Petroclival meningioma. So do you perform all Petroclival meningioma using this approach?
Look, what I can tell you is following. If the posterior part of the posterior fossa part of the tumor is the major point, then I recommend this approach. Okay, so and if the tumor is located on the left side and the patient is right-handed, I recommend this approach. So if the tumor has the major part at the middle fossa, small part at the posterior fossa, and it's located on the right side, then you can choose. You can go Kawase. You can do the approach. I think there will be no difficulty with that. But if the tumor is located below the interauditory canal, Kawase approach will be difficult to reach these areas safely. Then, so if the lesion is below the interauditory canal, the posterior approach is better.
Yeah.
Okay.
Yeah. Today, so Professor Eiji Komura also performed the same surgery.
Yes.
Even in the huge Petroclival region, he approached the two-stage surgeries: Retrosigmoid approach first, and followed by the Anterior Pestrosal approach he did. So
yeah,
as
the patients tolerate better. That's
good strategy. Now I understand. Yeah, thank you very much.
Welcome.
Thank you.
In that note, I would like to ask, what is your post-operative practice like? Do you give steroids for facial nerve palsies post-operatively?
How often do you give steroids? For what period of time? Use steroids in the post-operative setting?
Steroids. So we give 20 milligrams dexamethasone during surgery, and then for 3 days in the morning, 4 milligrams in the and approximately 12 o'clock we give another 4. So we avoid to give steroids at late on the day so the patients can sleep better. But I don't know if this makes so much difference, but this is our policy. So the single shot during surgery, 20, and then for 3 days. One point I forgot to mention, we have learned in vestibular Schwannoma surgeries that use of papaverine, local papaverine solution, brings more hearing preservation. because it avoids vasospasm. So since we have done this study in our department and it was significant difference, so we use in all these lesions, we use papaverine local application. You know, this is 1 to 30 dilution. You may use papaverine, you can use nimodipine, I think it's the same. And we irrigate the field several times during surgery with this solution.
Last question from my end. There's a certain number of patients that shows up with sigmoid thrombosis postoperatively. Relatively small number, but not uncommon. And what is your willingness to systemically anticoagulate the patient after P-fossa surgery?
Yes, I have a different case this week.
Yeah, me too.
Different case this week following vestibular schwannomas. And in our series, I must say, in our series now with 1,500 vestibular schwannomas, all of them retosig, I lost one case because of sinus thrombosis. So we have one mortality on this series because of sinus thrombosis. So it's relevant. When we have any injury to the sigmoid sinus during surgery, so my recommendation, don't put gel foam, don't put thrombogenic material. Put just a piece of muscle above to reconstruct the wall and fibrin glue surrounding this area, and then a cottonoid. So it's less thrombogenic than gel foam and so on. Nevertheless, it's thrombogenic. So what we do is, if the surgery is done in the morning, late afternoon, I do a CT scan with phlebography.
Right.
Yeah, to see if there is any signs of thrombosis. And then we start giving heparin intravenous. Then it's always the discussion, 20, 40, you know, this is always a discussion. So if at the CT scan, we don't see any bleeding, if it's really clean, then we give 40 units. Yeah. If 40,000. If there is any bleeding, something you are worried about, hemostasis, then we give 20. It's not scientific, but this is the way we are running well. So, and we give these, in Germany, the patients are not discharged one day after surgery, like in some other countries. We keep the patient some days. And when we discharge the patient approximately 5 days after surgery, we can switch to Clexane.
Shara, any other question you would like to bring up, or can you do a few summarizing words and close the session?
Would you like?
I wanted to ask Prof. You discussed about safe surgery, remove what is required. My question is in two conditions. One, if eventually the HPE came back as a grade 2 or grade 3 meningioma, what would you change your plan? Will you go in again? Secondly, if the tumor is encasing a major vessel, for example, a basilar artery, what is your strategy in these cases?
The first question I didn't understand well. The second I understood better. Maybe somebody can repeat the first question again, because it was some problem with the acoustic.
I think the first question was related to if the tumor comes back with a high mitotic index and is a WHO grade 2, yeah, would you contemplate going back in, removing the residual, or would you change your post-operative strategy for adjuvant radiation?
Oh, I can only detect if it's a grade 2 at the recurrence if I operate it. Otherwise, I can't see that. Yeah, that means if there is recurrence, I operate this recurrence. If the patient, if this lesion became grade 2, I detect this just 1 week after surgery. Yeah, the pathologists need 1 week. And then we go for radiation after surgery, of course. This is a clear indication for radiation. And this may happen particularly in men, more commonly than in women. Yeah, we must be very careful with men having those meningiomas. And the second question was basilar artery. So the basilar artery is not a problem. You know what the problem is? The pontine vessels. The basilar artery usually is not infiltrated, and you can separate the basilar artery. But when you dissect the basilar artery, sometimes a pontine vessel may rupture. And then you may have an infarction of the pons. This is the major point. You must be very careful not pulling out the lesion so much. You must be sure that the vessels are dissected. Must be done very carefully. Yeah. And I try to avoid at maximum bipolar, because with bipolar, I don't know what happens with a hyperthermic effect of bipolar on the nerves, on the vessels. So I use a lot of irrigation, and this is one advantage of semi-sitting position, that with irrigation, you keep the field clean. You don't need to use very much bipolar. Bipolar I use, of course, to close the feeding vessels at the Petrous code. That's of course. Otherwise, we try to avoid it.
My second question, Prof. In deciding whether you want to come Kawase approach or reverse Kawase approach, does the T2 signal in MRI used to determine which approaches? Because it may be suckable tumor are more suitable for reverse Kawase than a non-suckable tumor. What's your opinion, Professor?
Yeah, I don't know. I cannot answer this question correctly, but I would say if there is more hyperintensity, there is more attachment between tumor and higher matter of the brainstem and veins. So I would feel more comfortable to have a direct view to this lesion. So I prefer posterior fossa.
Yeah. And Prof, you did show us the pre-metal drilling. My question is, do you routinely do the drilling so you have better exposure and less retraction in your cases?
No. If the bone is disturbing the view at the beginning, I drill it away. Okay. But if not, I do this later on when it's necessary. And when you drill this area, my recommendation is to put a piece of glove on the surrounding area to avoid that your drill may capture nerves and vessels. So I have one case in our series. I was drilling this bone, and then suddenly I captured the facial nerve. And I didn't understand why. And I checked again the video, and it was very interesting to see the drill produced suction. And I saw the arachnoid being, pulled towards the drill, and then the facial nerve as well. It was since that event, I always use a piece of glove to protect the surrounding area.
Yeah, my last question, Prof. In deciding or advising patient for conservative follow-up imaging, do you take the age as consideration, especially in female, whether they are premenopausal or postmenopausal in deciding that, Prof?
Yes, the younger the patient, the more likely to develop recurrence. But we try to calm the patient, like this pregnant woman who came with this lesion. She came desperate because some other people told her she must be operated immediately, she's endangered, and so on. This is not correct. I told her, of course you can wait 1 year or more. You shall not wait 10 years, but you can wait 1 year. And she did it. She got the child, and when everything was fine, the surgery was done. So we must talk about long-term perspectives for these patients. But it's very uncommon that this lesion represents immediate or acute threatening to the patient.
I think we can close this webinar for now with your permission. So on behalf of the Education Committee of the ACNS and the President of Yuko Kato, I would like to sincerely thank today's speaker, Professor Prof.Tatagiba, and the chair, Professor Eckhard Casper, for coming here and teaching us about this very interesting retrosigmoid intradural suprameatal approach, or otherwise also known as the reverse Kawase. Thank you very much for teaching us. Thank you, Dr. Liu, for joining, and all the attendees who joined.